My name's Andrew Burke. I spoke in the first session, and our first speaker is Dr. Kate Mccarthy, friend and colleague of mine here at the Royal Brisbane Hospital, and Kate's an infectious disease specialist working here, and she's also a microbiologist at Pathology Queensland. And Kate's the clinical lead for the OPAT service, so the ambulatory hospital and home service, and she's got research interest in antibiotics and how we administer them. So thanks, Kate.
Thanks, Andrew. So I've been asked to talk today about TDM in the community. And so as Andrew's alluded to, this will refer to hospital in the home patients and also called OPAT patients or outpatient antimicrobial therapy patients. So the models of care for OPAT and HIF vary, certainly across Australia and also internationally. And there are many drivers of these models of care, but effectively what we end up with is either antibiotics administered at an ambulatory care centre, being administered at home, or administration at home by nursing staff. And this might be given by an automatic infuser or by a pump and a bag as well. So what this tends to lend itself to, both economically and related to workflow, is antibiotics that we can use that only have once daily dosing and at worst twice daily dosing. However, in the Australian and British setting, we tend to favour 24-hour infusions, particularly relating to our beta-lactam agents that are really the workhorse of these programs. We'll come back a little bit later to the 12-hour infusions and discuss them. So we've talked previously about the pharmacodynamic index correlated with efficacy of antibiotics, and clearly by giving these antibiotics as infusions, it really tailors into maximal efficacy of the drug, provided we have adequate concentration. So this was a list from a paper written by Jason in 2011 about candidate drugs for TDM. And traditionally, as been mentioned previously, HIF and OPAT are very used to monitoring vancomycin and aminoglycosides because of their low therapeutic index. But discussion is more moving around achieving efficacy, particularly in patient populations, I should say, that are more challenging. So when we talk about HIF and we look at a continuous infusion where the drug levels are represented by the green line on the diagram, you need to remember that sampling is from a single point in time that tends to relate to the time of infuser or bag changes when the nurse is able to see the patient. And it's normally taken after a 24-hour period when the dose is adjusted, once we've reached steady state. Now, community TDM has its own set of logistical challenges that aren't encountered in the hospital setting, where the patient is readily available for many drug levels potentially. So we've talked about sampling needing to occur around the time of a bag change, but there's a whole influence of workflow. So it has been tricky at times to actually achieve on the services antibiotic bags being changed over at sort of the 24-hour mark. And this is because workflow, nurses as part of their work can be held up seeing patients. We know that in hotter temperatures, the balloon infusers, for example, can infuse faster, so the infusion might have finished before the nurse gets there. And in the last few years, we've had to deal with floods where we couldn't actually get there at all. I guess the other logistics involve process for sample transfer. So this is not once we take the blood sample, it can't be thrown into the back of the HIF car, but there needs to be a process around putting the sample on ice and transferring it efficiently to a lab receipt point, which might not always be on the drive that the nurse was originally planning to take patient to patients. All of this involves staff education. And then really, if you are going to do TDM in the community, there needs to be some effect. So if you're not happy with the antibiotic level that you've achieved, there needs to be a way in real time that you can actually change the antibiotic dose the patient's receiving, which can be difficult when antibiotics are ordered many days in advance. So if we move back to that list of reasons for doing TDM, I would actually add on to that list in the community that TDM can be used for the purpose of concerns around drug stability. So we know that the stability of drug in an infuser or in an antibiotic bag when it's made up as an infusion depends on the temperature of the solution. So if you can imagine, most patients carry their antibiotics in a bum bag around their waist. And as such, there is not only the temperature of the host, which adds to the temperature of the bag, but also the ambient temperature, which is probably more important in non-temperate climates. The stability of the drug also depends on the achieved drug concentration, the concentration of the solvent, the type of container holding the solution, perhaps less important because most are plastic, and also whether you utilise a buffer. And in general, if we look at the data that we have on antibiotic stability, the majority of this work has been done at room temperature, so not reflecting the range of temperatures that patients in non-temperate climates might experience. So this was a study we did around 2 years ago, and it actually happened to be coincidentally the hottest summer in Queensland for some time. And we had a number of participants, the majority of which were pharmacists, who carried antibiotic infuser bags in a bum bag across waking hours in the Brisbane summer weekends. Overnight, the bags went into the fridge. And what we found was that during waking hours, 50% of the antibiotic bags had temperatures up to 30 degrees Celsius. For 30% of waking hours across the summer, it was between 30 and less than 35 degrees Celsius. And then we had these really high temperature spikes, which on questioning were really related to entering closed vehicles or closed buildings that had not been cooled previously. So this temperature variation in a subtropical climate really has no reflection on the stability studies that we have for our antibiotics. This also might affect how rapidly a balloon infuser delivers its antibiotic, and also these temperatures here might cause accelerated degradation of a drug. So moving on to those antibiotics which are a little bit more unstable, and today we'll focus on Ampicillin and Meropenem. These antibiotics are often not given by HIF and OPAT services due to concerns around stability. What we utilised was therapeutic drug monitoring to really achieve safety in the community setting while administering these drugs. Now, this paper here is about ampicillin, and this was after there were a few case reports showing clinical efficacy of infusions in the community without drug levels. So we had 3 patients of differing conditions, of which we put on BD infusions and then took levels every 24 hours in the community. Now, the MICs of the isolates were ranged from, I think, 2 to 4 from memory, and they're all Enterococcus faecalis. And as you can see, the range of ampicillin levels is on the right of the table displayed. If we look at these a little bit more closely, what we did before they went out is that we did a level on an intermittent infusion. We then moved them onto a continuous infusion in the hospital setting. And the reason we did this is that we took this level as our gold standard because the patient was at room temperature in which we knew the drug would be stable during the infusion time. We then took levels in the community weekly, or more as required if we were concerned, with really close clinical review. And as you can see, from a level of 18 in the standard temperature of the hospital, the latter levels are what we achieved. Interestingly enough, this final level at the bottom was after there was a 1-hour delay of the nurse attending the patient's home to actually take not only the drug level, but also change over the infusion. If we look here and really probably at this second patient here, this was a patient with impaired renal function. And as you can see, the levels were very high as a result of that. So I guess this brings us to the question of what is the target drug level for a patient who is in their subacute phase of illness in the community. So on previous talks, we've talked about maximal bactericidal activity being reported at 4 to 5 levels of the drug concentration above the MIC. We've talked about how the level in the blood does not necessarily reflect the level at the site of infection, and there are differences in inoculum of the infections. But also, when we move on to these services in the subacute phase of illness, there's been a chance to reduce the inoculum through surgery or antibiotics. We're at a latter stage of infection with less pharmacokinetic variability. And also, we're giving them a continuous infusion, where theoretically we should actually achieve 100% of time above the MIC. So I don't have the answer to this question, but I don't know if it's still 4 to 5 times above the MIC. We'll move on to meropenem for a moment, and this is a paper from Manning et al. And what they showed was that traditionally we haven't given meropenem on these services because of concerns about instability. And what they did again was they had antibiotic bags made up with meropenem of differing percentages, so 1%, 2%, and they cooled them and didn't cool them. And then they looked at, by sampling those bags over a 24-hour period, they looked at how much drug was actually available. And this suggested that they're actually, with cooling of the bag and using a lower percentage, that we could actually have adequate amount of drug delivered to a patient in the outpatient setting. So based on this, we then followed 4 patients which we discharged on meropenem, and depending on the amount of drug we chose to give, we either gave it as a BD infuser or a 24-hour infusion because we wanted to stay at that 1% level. In all cases, we ended up having clinical cure, and really the candidates, we don't use a lot of meropenem on our service, but the candidates were patients that had resistant gram-negatives, or nocardia pneumonia. Now, what I wanted to show you here just in more detail as we look at the second patient initially. So in the hospital with a continuous infusion at room temperature, we had a random level of 19, and we really achieved relatively similar levels in the community. On this patient here, we actually had a level of 18 in the hospital, and then we went to levels of 16 and 20 in the community. But clearly this level of 2.2 when it came back, with all the delays related to the logistics we've talked about, was a bit of a heart stopper. And basically that related to an infusion, a pump malfunctioning and the infusion being stopped that was going into the patient prior to the drug level, a number of hours prior to the drug level being taken. So I guess the point here is that this monitoring is a dynamic process and really needs constant clinical review and drug levels to ensure that we are actually achieving adequate concentrations of medication. So what I thought of there was very originally in the sessions Jason mentioned, we have to think about the drug, the bug, the mug. But I wonder if we have to worry about whether our community patients are smug, meaning that they're actually sunbaking as opposed to sitting and shivering air conditioning to maintain the stability of their antibiotic. I apologise, I couldn't think of anything better. So there are many pros and cons of putting people onto HIF and OPAT services. And I think TDM in the setting of non-stable antibiotics allowed us to give patients the benefits of HIF and OPAT in the community setting without the disadvantage of giving them inadequate drug levels due to potential instability of the drug. If you ask me what my Christmas list would be, ideally we would have same-day result or point-of-care technology and the ability to respond to that. We'd have earlier predictive models of TDM and steady-state levels, and we'd also have further TDM studies in the community setting, so we'd have greater understanding. Thanks very much.
Thanks, Kate. That's great.